but in general, what guidance can you give us in terms of communicating? Any ideas on that?
I think young people and children and young people are very complex, and they got their own different ways. And then
Yes.
you also encounter you have a range of people with different, how they communicate with people is very, very different in terms of they might have a medical need or additional learning needs. So there is not just one point, not one answer to cover a range of it I can tell you of. But I know young people, they use a range of ways to communicate, like how they communicate with their friends. I know WhatsApp is what they use to talk to professionals, but there is no one answer I can say at this moment in time.
I think that's a really good point. Yes. Any thoughts, Scarlett?
I suppose I was just going to add to what Alex said. I think it's hard to. So I certainly can't speak on behalf of all children and young people, and I think it's hard to talk about communicating with them generally, because every child and young person has their individual preference for communicating. So sometimes it will be face-to-face engagement, whether that is with the health professional they're consulting, or perhaps at higher levels. Sometimes it is through emails or text messages. So I think it varies, but one thing that is important to children and young people, I believe, is a constant stream of communication. Even if there isn't a kind of general one method of communication, that constant engagement with a child and young person, that reassurance, the presence of health professionals in a dialogue with children and young people, I think it's not a general mode of communication. Not a general mode of communication, but consistency in communication that's important. If that answers your question.
Yeah, good point. Yeah. On the public, David, Gareth, Sian, Chris.
Diolch. Thank you. This is again one of the most, since I joined the board, this is a really key moment in us hearing you both yesterday and today, and how important that is. We're thinking about it from using the service, but for me, it's about young people at the future of this health board in so many different ways. I chair people and culture, so getting people into this organisation, people who want to be part of this organisation. This is all a key part of that. Is for young people to understand what this health board is, what it can be for them and their families and their friends. So again, I just want to thank you for this morning and for yesterday. Diolch.
Nessa, Gareth, wedyn Rhian.
Just very briefly say, I think it's excellent, really excellent piece of work. You can all be really proud of it. I particularly like the poster, which I think is so effective, and I hope that we will have that very widely displayed. I also want to say it's a slightly possibly more controversial, but why it's such a good piece of work is that it accepts without giving in to the fact that there's an imbalance in power between, the expertise of clinicians and young people, but it sort of takes that as a given, because often and then says, what can we do to work within that to make the experience create positive for children? Because all too often there's a lot of glib talk about co-design or co-decision, but obviously the relationship with people who've got specific expertise, you need to know that, and what you want is to harness that in a good way for young people. And I think you've recognised that. So I think that's a real tribute to the maturity of this piece of work, and genuinely very impressed with it. And thank you for being there. And I'm sure we all can sign up to it. But it's not us that need to operationalise it. It's out there, and we will have to. Sure, Carol will be making sure it's cascading through the organisation, and having one piece of paper that shows the main points is so important.
Yeah, thank you. When I saw the poster and heard you speak, building on this charter should apply not just to children and young people, it should apply to all the people with whom the health board comes in contact, shouldn't it? You know, older people who need their voice heard, people with different needs. So I think it's got a wider application, really, and we need to think about how we communicate the same messages to all the people who come in contact with us. And for that reason, I found the little bit that said prioritising children's rights a bit problematic, because we've got so many priorities that we constantly need to juggle. And I think what we want is for everybody to be treated fairly and equally, and the voices of everybody heard. So I think your message is great, and I think it goes to a higher level as well, a broader level. So thank you for that.
Diolch yn iawn. Chris, wedyn Claire.
Thanks, Chair. This is wonderful, really is wonderful, and holds a very special place in my heart insofar as I've benefited immensely from very similar projects when I was quite a few years ago now in your position. What I really want
As
to
the youngest board member.
Yes.
Thanks for that.
A comment more than anything, and I think, and to add on to what Dr. Jones has said, I really hope that this isn't the full stop. This is a pause in the work, and hopefully we can see, just by the contribution you've made today, the real effort and real contributions you have to make. As Dr. said, you are the future of the service users, and perhaps the future of the health board as well. And I think your contributions and those of each be incredibly important, and perhaps there could be in the future a piece of work that looks at drawing together, and it's certainly done in other organisations where we have a children and young persons board, and the contribution that can put into the health board is almost without measure. So really well done, and great to see. Massive fan of your work.
Diolch yn iawn. Claire.
Diolch. This is a question for Carol, really. So taking, and I wholly support everything everybody said. Great piece of work. I really want to, agree to it and support it today. So it's a question really about, I guess I'm seeking assurance from Carol that there is a plan in place to operationalise this inside the organisation, to communicate it, to make sure that at every point of our 20,000 employees, people know what this is, they know what it means. And then I guess thinking back to the first item around looking at sometimes where things go wrong or complaints, what is the route for young people when they don't feel we've lived to these values and to these ways of working that we're all signing up to, really. So I'm not asking you to tell me the process for doing it, but I guess for the board to have some assurance that we've thought through how we might do those things. And I guess in terms of the future then, when we're looking at our performance around quality and customer services, we ought to start to see some indicators of feedback from young people about service delivery, service transformation, services being, adjusted to suit the needs of children, young people, as well as to work well for adults. So
I'll give Carol an opportunity to address that important point, and in particular, also how are we going to involve children and young people going forward, not just taking this work now, but a general involvement. And I think there's a really good point about you helping us inform us about services that are needed today, but actually also telling us how maybe services should be for the future as well, not just for today, but when young people move up into the next generation, what should services look like then? You can help us shape the future of services, not just tackle issues of today. Before bringing Carol in and anyone else, just ask you if you want to add anything to emphasize or anything further you'd like to share with us. Yes, please do, Liz.
Just a short few words, picking up the...
If you can speak up as loudly as possible, I'd be grateful.
Quick cough. Picking up the point that Leanne made, which I totally support, because I'm a great believer that actually we could improve our listening and our interactions with all of our patients. I've always believed that. I've been around a long time, as I say. And for all ages, I totally agree. I think the key message that we want to impart with this, which is important at the moment because I don't think it is clear, but hopefully as we get better at it, it will become much more even, is that a lot of people that work here or that children, young people have to engage with, don't understand that children have rights and actually have to be understood and dealt with in a little bit of a different way.
Yeah.
It's fine for some, but it does depend on circumstance and background and opportunities and life experiences as to how that fits with this scary world of adulthood. I will never forget the moment when one of my two girls, who I will say, you may imagine are pretty able, but I remember it very clearly the moment she said, "Oh, this adult world's a bit scary." And she was about 23 at the time. Actually, the message there is very much around the fact that children are a bit different and we manage them differently to an adult, especially an elderly person. So I totally agree with you, because I hope when I'm much older that I get spoken to in an open way with all of these attributes on our charter. However, there's some learning, I think, for a lot of our colleagues to actually do.
Yeah. Diolch yn iawn am y pwynt yna. Helen, and then Carol to wrap up.
Very, very quickly. I just want to thank Liz and Scarlett and Alex and Jane. I've been on this journey with you on the periphery, and I think it's amazing. So I just wanted to put that down on record as well, because, you know, you've done amazing things. Thank you so much for getting us to this point.
Diolch yn iawn. Carol, i gloi.
Great, thanks very much. So there's loads in there, and I'm just going to invite Andrew to say a quick something, if I may, on operationalisation. But for me, this sort of work is a sign of leadership and commitment at the board level. It's about what we stand for and how we will take things forward in a very genuine way. I've had the pleasure in my career of working with children and young people. They're a tough gig, you know, in a very straightforward way. You know, you bring the reality of life for you. We were all children and young people once, but we're not children and young people now. And that's the thing, is that you bring today's world and hopefully tomorrow and the future, you know. Because that point about we're here as custodians of the NHS, we're trying to create a better future. We need people to help us to do that. So I think that it's a strong sign of leadership and commitment. I think just to pick up Mike's points around how, in my experience, is broad routes of engaging. The last thing we want to do is to ask children and young people to come to our committee meetings. And you know, I've heard feedback that it can be a bit dull. Sorry, guys, but actually we go where children and young people want us to go, and we engage in the way that they want us to engage, and that requires a flexibility on our part as well. In terms of a couple of points of implementation. So I think there's so under the Children's Act 2006, and there is different legislation that's come in afterwards, but we should at least once a year take a review of how we work with children and young people in developing our services, and how well we're operating. And Alex made the great point of it's not just about children's services, it's about wherever children are in the organisation. So at least once a year we have that report come through, and we're able to then demonstrate where children have been able to influence our work and the impact that that's had. So I think we should hold ourselves to that test. But if I could bring Angela in briefly on operationalising.
Yes. And what do we mean by operationalising? Because
Making it happen.
that's a heck of a word, isn't it? But what does it mean? Tell us what it means.
So I think it's about making it happen. It's making it live, making it real, and making everybody aware of it.
Yeah.
So I had a bit of a delegation come and see me probably not long after I started from the team, and we had a really, really good couple of hours in the boardroom. And one of my team from the Office of the Nurse Director has been supporting Jane and the team around the operationalisation. So looking at how we can bring it in. We were talking about, ED department, that first contact, how we'd make sure that was happening. We talked about youth councils and things like that. So a resource to support really and to navigate. So for me, this is amazing that we're now at board when we were talking about it in a boardroom a couple of years ago. So so we are trying to make sure we've got an implementation plan. We're identifying the areas that are the key spots. We have children's departments and EDs, but we want the whole of the ED to understand it. We've got children's wards, but we want the surgical pathways, the medical pathways, radiology, and it's about mapping it. So Sam Watson, my team, has been working with the team to try and support that.
Great, diolch yn iawn. So, just to confirm then, the request is that we endorse the Children's Charter and we agree to commit to implement it across all service areas in the health board. Are we all happy to do that?
Yes, we are. Wow.
So can we thank you for all the work you've done and coming along today, which is quite a commitment, and we want to see you again. Not necessarily here in this room, but we want to see you. We want to be able to learn from you further, and we want you to help guide us for the future. So hopefully we'll have the opportunity to do that. But can I also wish you well with everything you're involved in? I think you're both studying at the moment, I think, if I'm right. Really wish you well, and always remember the health board will be here in the future too. There's always an opportunity to engage with us whenever you feel, even if it's, you had a bright idea one weekend, share it with us. We'll be really grateful, because what we need is inspiration, and you can provide that to us. So many thanks for all your work, and we wish you well for the future. Diolch fawr iawn I chi, a diolch yn fawr iawn I Liz a Jane hefyd am gefnogaeth. Diolch fawr iawn.
Thank you.
Reit, symud ni ymlaen i'r
We'll
eitem
therefore
nesaf.
move on to the next item.
Gofal brys ac argyfwng. Wrth gwrs mae'r eitem
Emergency
yma
care.
yn un o'r eitemau.
This item is one of the items that we've recognised as an item that requires attention from the board, special attention from the board. We had a session on planned care in our last meeting, and this time we have urgent and emergency care.
Felly dwi am droi at
I'm
Carol.
going to turn to Carol and Imran.
I'm just going to say a couple of things. It does feel like it's urgent and emergency care themed board today. And I mentioned earlier in my report the focus really on urgent emergency care as a major programme. So this is the first key step for us as a board. There's a bit more to come at a subsequent board, but I'm going to just hand over to Imran, if I may, at this stage. Thanks, Imran.
So I'll take the paper as read, and in particular, really important as we approach winter and winter's upon us, to really drill down and have a deep dive around each of our areas, from the front end all the way through to the back end, in terms of following the patient pathway and looking at some of the challenges. So the realities at the moment, as things stand, is that on a daily basis, looking at September, we've got 65 patients per day that get delayed at the moment in relation to the 1 hour ambulance wait. Now, that's not great in terms of patient experience. Again, Carol, Angela, and other colleagues have already mentioned some of the challenges around that, in particular, that not being acceptable from a service provision point of view. The second element as well to note is that 4 hour ambulance delays, and our Welsh ambulance service colleagues work very closely with us, and there's obviously more work to be done around that, and concerns over our waits. And that basically, as things stand at the moment, is 23 patients a day that wait for 4 hours. But one thing just to say as well is I've had the privilege of going around and meeting colleagues across all our areas in the front end, really engaging with colleagues. There's a lot of hard work and effort that's put in every day with patients first. So that's a really good thing to feel, and certainly being new in the board after returning back after 5 years. Again, that feels really good in terms of that commitment and focus. So there's more to be done from a patient perspective, but as well as supporting colleagues in the front line. And I just need to emphasize that, but also to thank WAST colleagues for their support on a day-to-day basis, particularly balancing the community demand as well as what happens within the emergency department. So again, there's work to be done collectively there. In relation to 12 hours or more patients staying in the department currently, that's 116 patients per day. Now, that's where we are at the moment. When I've looked at some of the data, and it does show within the deep dive, is that there is that variability where some days it's improving, some weeks it's improving, but it's not consistent. So we do need to look at that. So that's the bit that I'm going to be focusing on later in terms of how do we have a more consistent approach in managing that. The other bit that I would say, just drawing from some of the conversations that colleagues have had, is around the packages of care delay. So these are delayed transfers of care within the hospital. So in August, just looking at some of the data, in totality, we had 10,952 bed days that were consumed by patients that were not in the right place, not in the right environment, not receiving the care that they needed at that time because their acute care was over. And a number of these patients are elderly patients, and we wouldn't want them to decompensate. And a lot of us have probably had that personal experience, and it's not really a great place to be. So we need to do something about that. And that translates into 353 beds, and that's equivalent to a district general hospital. And that's what the teams have to manage across our 3 hospitals as an aggregated position. We also need to look at things like time to triage, the senior decision making, and what's happening at the moment is because of the delays, particularly in the back end, and the consumption of the bed days that are probably not appropriate, but probably the safest at that point in time for the patients, whilst waiting for discharge packages of care. That creates a backlog all the way through. And what that also means is that our discharge times over a 24-hour period, again, that's in the deep dive, is that there is a real peak at the end in the evening, which is after 5 o'clock. And what we need to do is to shift that more towards the left. So we have earlier discharges, earlier release of beds, and then we manage that more productively. And Angela and I were talking about, as Angela said, around how do we manage that with patients who are ready for discharge for the here and now? And how do we manage them safely and consistently so that they're able to be managed outside of the beds in readiness for the discharge, whilst we get the discharges earlier? Because obviously, all the while that there's delays, there are patients waiting from ED and other areas to be admitted into wards that they can't access because of the backlog of delays. So it's a complicated picture, but there is a solution around that and things that we need to be working on. We've also touched on, as the chair said, around the corridor care and all the other areas where patients should normally be managed and cared for. But to manage care safely, we've also got to manage the risk in a broader sense, because whatever the space issue, patients need care there and then. We've got to provide it in the best possible way. So corridor care, unfortunately, at the moment is a reality, but the key is how do you manage that safely, consistently in the time that we have to manage that, but also more importantly, for it to be time-based as opposed to long duration of corridor care. So these are all the things, just to highlight, that we're working on currently. So in the report, in terms of the solution, an overall 4 work stream approach that encapsulates the 6 urgent and emergency care goals. And the urgent emergency care goals are exactly that. They're the goals that we need to achieve in terms of best practice. What's really important is how we get there. And the way we've agreed to get there in terms of process, and hopefully that assurance by the board will be critical, is moving the front door. So this is around, and again, Gareth Vice Chair's point around primary care and getting that really into a substantive position, substantial, and it's really key as a service, is moving the front door closer to patients' homes, having our community services reaching out, having what we call a step-up capacity. So when patients do need that care, it's available for them to step up to, rather than emergency department. Welsh ambulance service colleagues, very important to work with them in partnership to get the care pathways right and to get that resolved. So moving the front door is going to be critical, and there's a lot of work that we've started off around managing falls, patients who've had a fall, patients who have breathing problems and chest pain. Again, that's in the deep dive as well, so we need to work collectively together. Jane, from her perspective as Director of Public Health, and myself working with local authority colleagues, and I'm pleased to say that I've been asked to take on the Senior Responsible Officer role for North Wales around Care Action Committee, which basically looks at all the local authority elements and how we could improve services in the community in particular. So that's good, and I'm actually meeting them tomorrow to go through what I'm presenting today. So we've got a team approach. The second bit in particular is around our emergency department and emergency quadrant, and really focusing on that and the processes, handover processes, and looking at a provision of care, particularly around how we manage corridor care for the here and now. But neither of those will work if we don't have the third component sorted, and that's the hospital flow. So the day-to-day discharges, the day-to-day discipline of having that focus around patient care, ensuring that we plan ahead. So if I'm a patient and I'm being discharged tomorrow, getting all that ready today. So first thing in the morning at 8 o'clock, I'm ready to be discharged. And that means that there is an early bed available for patients who are waiting in emergency care, and shifting that earlier and earlier. So we then start reducing the backlog within the emergency department, the assessment areas. So that's going to be key, and we're going to be focusing on that. And finally, the discharge into the community bit is really important as well. And that's the 353 beds that I referred to for August as an example. So in summary, what we're going to be doing is having a 12-week urgent and emergency care focus. We're going to look at all the 4 work streams that I identified. We've got 2 leads per work stream, so we've got consistency in leadership. And it's a whole mixture of about 15 colleagues across the board at the moment that are a mixture of senior clinicians as well as operational leads that are going to be looking at health board-wide leadership to really improve this and standardize our practice across the board. And the 12-week urgent emergency care process starts next week, glad to say, where we'll be looking at 2 weeks of resetting, checking all our standard operating procedures, looking at our professional standards, sense checking those, are they working, if not, why not? And the daily improvement focus by improvement teams with an improvement lens to say, if things haven't worked today, what could be different? How could we manage that differently going forward? So that's essentially the work that we're going to be doing, and we'll be presenting that, the progress around that at our committee meeting, ensuring that that obviously is looked at in terms of assurance, and the committee meeting is performance, finance, information and governance committee, where we'll look at the details. I'll stop then. I'll open up for questions.
Great. Diolch yn iawn, Imran, and just adding to what Carol said about the welcome, you have been thrown in at the deep end, but you are swimming and you've taken it to it really well. So we're really grateful for the commitment you've given right from the start. So we can have loads of questions, I'm sure, on this topic. So Gareth, wedyn Rhian, wedyn Teresa, wedyn Mike. You gychwyn.
So first of all, Imran, yeah, you have been thrown in at the deep end, and thank you for this work. I mean, so if anything I say is sort of critical, which some of it will be, it's not about the quality of your work, and it's certainly not either about the quality of what the staff are doing in emergency departments. I think, and I'm looking forward with my chair of PFIG hat on to getting my teeth into this. I think, I mean, I think the paper is really strong on the analysis, and if I can draw the parallel a bit with our planned care, I think it took quite a long time to move beyond knowing what the problems were and even what the solutions were to actually implementing them. So I like, I think I'm really interested to see how the 12-week cycle goes, because obviously we've got. Is so even less time with this to make real improvements than we've had with planned care. I did feel that we perhaps, by emphasising that it is an all Wales problem, we sort of slightly underplay how much we are an outlier, and a particular discussion we had yesterday, an outlier from a bad point of view. I know, sort of anecdotes are not evidence, but, the evidence is that we are 7th out of 7, aren't we, in terms of the 12-hour waits. But I was really struck, as part of our meeting of vice chairs, I was at the Wales Ambulance Services Trust headquarters in South Wales, but where they are responsible, I think they coordinate the ambulance movements for the whole of Wales. And I said, I know that other parts of Wales do have problems, but on the day I happened to be there, the only place there were problems with ambulances being stacked up outside without being able to discharge was in North Wales, and all 3 of our hospitals have them. So it brought home to me that, and they weren't being, I think they're realistic, they know what the problems are, but from them that they were clear that wasn't a one-off incident, although there are problems at places like the Grange and Morriston, that consistently there are problems in North Wales in a way that there aren't elsewhere. So we're at the sharp end, as Carol always says. I think I'm misquoting you, that because we've got a lot of scope for improvement, it's perhaps easier to improve than places that have tried everything and still have got problems. But we've got a big mountain to climb. One thing I thought, I guess, was not missing, but particularly in your actions, the 4 work streams, and perhaps it's just because we can't move quickly enough, but I do think that, our minor injuries units have got much greater capacity in both senses to deal with. So when you look that, the top reason people are turning up is, and it says minor, I don't know if they are all minor, but minor head injuries and then sprains and ankle injuries, those sorts of things are what MIUs are there for. And we do have this problem, which is not, again, it's not their problem, but one of the things that WAST have said is that I think about 4 of the health boards in Wales, they have places where they can convey patients other than ED, but 3 of them, including, I might have got the numbers wrong, but 3 of them definitely, including Betsy's one, where they don't have anywhere else that they are sort of directing their staff to take people to, and that's to do with their lack of certainty about what is provided where. Now, I don't know how flexible and up to the minute, if you like, their directory of services is, but I presume it's online. So I presume there must be some way of saying, that the one at as Betty Primrose Stanley is open these hours, but we've got to get that right, because these MIUs are actually probably underutilized. So that's my big point, really. And I will just say the other thing. So you're absolutely quite right. Of course, you know far more about it than I do, about the problem being, the bacteria. But unless I've misunderstood it, I think all the evidence I've seen since I've been on the board, and I don't think this has changed particularly, is that, there is still a substantial proportion of the weights that are due to our things that we are in control of, particularly medicines. And obviously the EPMA system, if that's the right term, should eventually help with that. It's probably slightly longer term, but medicines and also assessments of patients. And the then minister, when we met him, Mark Drakeford, did raise the point about trusted assessors. And I think there was a little bit of looking around the table as it's sort of knowing it's not really working. I don't know what the reason is, but there are things there that, again, probably not quick wins, but definitely we need to be, as well as sorting out what we can do to compensate for the problems with social services, because we can't, we just need to make sure that we've done everything we can to reduce that proportion of overstays, if I can put it that are waiting for stuff within the health board's gift. Sorry, I've said more than enough, but no, thanks for the paper, really interesting.
Great, and what we'll do, Imran, is get questions from quite a lot, a range of questions, which will give you and Carol and anybody else an opportunity to come back on some of the themes that will develop, I'm sure, through the questioning. Right, Nessa, Marian, wedyn Teresa, wedyn.
I think it was just picking up really the same sort of things that Gareth was talking about. You talked quite a lot about the back door, the discharge end, but I think I'm not 100% convinced that our front door arrangements are right. There is a lack of clarity about who can do what, and therefore the default position is take somebody to A&E, be it in an ambulance or be it with a carer or a family member, because we don't know what all other services are that can divert people into maybe a more appropriate setting. So I think getting the front door right is pretty important. You know, I've spent time in ambulance car parks of hospitals and asking ambulance drivers and the paramedics how long they've been there and why they're there. Couldn't they have gone somewhere else? And there's all sorts of logistic reasons why it's a default position to go to one of our 3 A&Es. But I think there must be a way of being able to direct people better and use the great facilities we've got in our MIUs, in our same-day emergency care, in our out-of-hours services. They're there, but I'm not sure people know how to get to them at the right time.
Diolch yn fawr iawn. Teresa, nesa.
Diolch, yn siarad yn Gymraeg.
I will speak in Welsh. 2 comments, if I may, Chair. First of all, looking forward to working with Imran in this new post. Seeing so many opportunities for the professional workers relating to health and diagnostic to be a part of this work. Even in emergency, when we look at the 4 areas that Imran has set out, there are opportunities there to make so much more. And I don't think we're necessarily doing enough. I don't know if we can optimize the system entirely, but I see so many opportunities, and I look forward to working with Imran and wanted to put that on record today. Secondly, the importance that the emergency departments can cope with mental health patients as well. They do use the services as well, and quite often people come to the systems not only with medical systems but with health and well-being issues. I know there's great work happening already between the mental health teams and the IHCs across North Wales to make sure that we are safeguarding our patients whilst they are in the ED department, but that's important work. And as the Vice Chair's already said, that intervention work is so important. We have to be in preventing and early intervention. But there are opportunities when people have to come through the system and they come to the emergency departments during the winter, because so many people come through the system. I'm looking forward to working with Imran. But I do feel that it's a system approach, and we have to work as a system. Thank you.
Mike.
Next was Mike.
Yeah, I think the point I want to make is partly covered by what Gareth was saying as regards, in particular, the flow of patients through the hospital or not. I recently been looking at the pharmacy side of things, and in practical terms, on a day-to-day basis, what seems to happen, certainly from what I kind of witnessed, is that you get somebody doing a ward round. They wouldn't have a pharmacist with them, even though they were saying, right, we're going to send you home, Mrs. Jones, with prescribed such and such. And then that person, in practical terms, could be sitting there all day on that bed until eventually pharmacy gets a prescription late afternoon. And by which time, yes, she'll eventually get to go home. But we've passed the watershed of being able to change that bed ready for somebody else. So front loaded this, I don't know how practical it is in terms of staffing, but if we could front load that as regards pharmacy, we could get the bed empty quicker. So just a commentary.
Ie, diolch yn iawn. A dwi'n meddwl nesa, Mike, wedyn Claire, wedyn Jane.
Thanks, Chair. I was looking at figure 4, the ambulance conveyance locations and hospital attendant, and two things struck me. One is the size of the patch in IHC West and the Welsh ambulance area. It goes northwest, southwest, south, quite a long way.
Yes. Yeah.
Which hadn't really struck me before. But the other thing that struck me was there's overlap between the 3 acute units. Now I appreciate some of that might be people coming to Glencloyd for specialist services, but there's obviously, there's obviously overlaps between the sort of the east, west and the middle. Given that the performance of YGC seems to be the most under pressure, do we have any mechanism when we know that there are more ambulances in one site than another where we can notify Welsh Ambulance to divert patients if they're on the fringe?
Good point. And some of our patients, just in passing, some of our patients are from our region also go to Hywel to Aberystwyth, as happens as well. Claire, with Jane.
Diolch, not going to cover things people have already said. So just to pick up on 2 key areas, one around health inequality. So what struck me was the whole real situation as Glencloyd, and surely there are some shorter term solutions about how we can make better use of that minor injury unit there. So that's the poorest neighbourhood in Wales.
Yes, yes.
And that's having the biggest pressure on Glencloyd, and I'm sure it's been a factor in the quality of service delivered there. The other one actually direct to Imran is about risk and risk management. So I know this is going to sit in the PFIG domain, so I guess I'm asking the Vice Chair, we need to really think about our risk appetite in this area.
Yes.
I've sensed in my work with the board on this over the years that we tend to, understandably, take a very risk-averse approach to things. But actually sometimes in taking a risk-averse approach, we are causing more harm by keeping people waiting to get into ED or stopping people going home. So I guess it's just a request around some of the solutions may not be perfect, but they will help to move things along. So when PFIG is looking in detail at the plans for transformation around here,
assessment,
I think we really just need to consider our risk appetite and make sure that we properly risk assess. Because I've been involved in many discussions about some possible solutions, and it often gets but it's not quite perfect. But it could still be a big step from where we are right now, and we you know, my involvement with the board now over a few years, this problem's not improved at all. So we just need to approach it with I think a different set of.
So is it acceptable for something to be 95%, not 100%? Just
currently it might be 40. So
you know, in terms of the way we discharge and so on. So good point, Jane.
So 2 points. One, I think just to add to Claire's, I think some more work around the demographics of this and why people are attending ED departments would be really helpful. We know from other evidence and evaluation that people who are in insecure work tend to use emergency services more than. So looking at some of that might help us. The other thing is, I know because of the immediate pressures, the focus is very much on close to the front door and right through to the back door. But looking at the data again, I think we need to not lose the focus on moving that front door a lot further back. There was a lot more we could do about keeping people out of urgent care altogether. Looking at this around falls, around urinary tract, some of the major reasons why. And also we know that anybody over 70, more than 4 days in hospital, the start of deterioration means that the outcomes are likely to be worse, whatever you went in for. So the more we can do that actually says there are a whole group of patients that we should be just trying to keep out of hospital, and we should look at what those services in the community need to be to do that.
I think is a really important one, not just in terms of about what our urgent care targets look like, but also we're going to get better outcomes for that group of people.
Absolutely. Diolch yn iawn. Rhaid sylwyd y pellach dyn nhw Helen gynta wedyn Dyfed. Then we'll come to Imran and Carol to provide us with all the answers. Diolch.
Diolch, Derek. I just wanted to make the point that we have quite a comprehensive approach to signposting our population, and we do that through all of our channels, and we do that particularly when we know that there is a heightened need in an ED, and we do that through alerting people to what's available to them rather than telling them not to do something. But all the feedback that we get in this field tells us that the landscape for where to go, what do I do, is very, very muddled and confusing, even though we sort of know what is available. So in the urgent and emergency care recent workshop, people were listing what we've got. It was the comment. I've just gone back to my notes. My comment says this is far more cluttered and confusing than even I thought it was. So there is something about what is our offer. And clarity of that. And the reality is, when people need an emergency, they believe they're in an emergency, they'll go to the one place that they know, irrespective. And all our opportunities to get the message across to go somewhere else are missed in that moment because people aren't on Facebook when they need to go. So there is a big opportunity here. And the other point I want to make, it's the one I made earlier, is the third sector are very keen to support us in this area, and we must involve them in the conversation.
Yeah, some really good points there, Helen. Diolch yn iawn. Dyfed, dwi'n nesaf.
Diolch yn fawr am Helen, mae pwynt Helen.
Thank you, and Helen's point that Jane made previously was the same as I was going to make. We need to educate people to change their habits, and that's difficult because people's habits are their habits. And Helen made the point there that when things happen to people, it's an emergency for them. And then they think, emergency, where do I go? I go to A&E. And that's just instinctive, and we need to educate people. And maybe a point will come
dim troi pobl I ffwrdd, ond arall gyfeirio pobl pan maen nhw'n cyrraedd yr ED.
To redirect people sometimes in ED and to say, this is not the best place for you. Or others. That's difficult, and it's difficult to change. I'll change with the points that we have the young people here, and I go back. Young people come to habits, and habits are easier. That's the norm then. So I think there is work to be done. It's not older people like me with my old-fashioned habits. Thank you. And I'll bring Imran and Carol back, but just to build on that point that has been raised about the range of services that we have. Sometimes, as Helen said, it's complicated for us to understand. So how do we then inform the public about those services? There's a tendency by people to find things out when they need, and that's what I do. I didn't know anything about who was the best to put a window that was broken until this week, when my window was broken and I needed someone to fix it. I know that sounds dramatic, but that's the point. And that's how people get access to health services as well, generally. There are exceptions, of course. There are regular uses, but work to be done, and I'm not sure what the answer is. Sometimes I feel that when I sit in the car park I should be standing in the car park in Glenclwyd. I don't know what the answer is, but there is work to try and have that continuous discussion, not only with service users, but also with those who refer doctors and others. Do you want to come in, Helen, before I come in? If I bring Carol and Imran in?
Just to briefly make the point that the reason ED, I've been doing this for 20 odd years, the reason ED is the place that people go is it's consistently there. It's open, there are people to see them.
Absolutely.
The other offers, when I'm not saying this in Wales, where I've worked elsewhere, we promote the other offers and then they don't work or they don't give you what you want. People then revert back to the place that they know will be open.
And the whole image of the health service is, you know, promoted by all those TV dramas. It's about ED, it's about ED, so right, just Gareth, Chris, are we in?
Just very quickly to say that's why ambulance conveyance is so important. Because it will be difficult to change people who are getting in their own car. But if we can't change where the ambulance take people, then we're
good point.
Really,
and that's to do with where can we influence and who can we influence. Chris, and then definitely right.
Sorry, Chair, I thought I'd save everyone the tedium of this voice, but I seem to be treated more like
it's
seizing on Claire's example of real, and I hear exactly what David said about making sure that people perhaps even turn them away, that once they're not going to the right services. The difficulty with real, for example, is there's simply nothing else there.
No.
I'm on the Vets website now. I put in my real postcode and I get sent to Denby. It's not open all the time.
No,
there's nothing of particular use at the Alex.
So
really, the only place people can go is to Glenclwyd. Because if it falls that, so yes, messaging is really important. Service provision has to be a double track as well. And we can't be saying to people, well, you can't go there. There's nowhere else for them to go. It's fundamentally unfair.
And I was just reflecting, I was sort of playing in my mind this weekend. If there's an instance with my family, what would I do? I would very likely end up in a Ysbyty Gwynedd ED. That's the reality. But not that I would want to, but that would probably be where the path I would follow. Right. Lots of stuff there, lots of things to consider. This is a really, really important piece of work. We're not stopping today. We're grabbing hold of this with both hands. And we're going to do something. So Imran and Carol, over to you.
Absolutely, deal. So the director of services definitely is convoluted. I've already gathered that, and it's not unusual. We just need to streamline it. And if we could, what would be really good is to have that single point of access on a 24/7 basis, so you can have navigation. That is, it's out there. The numbers are out there, and the population know. But that's some way. But at the moment, the reality is, as we've already said, ED is the default place. We know that. So then that comes back to the risk appetite, and particularly working with clinical colleagues in the front end, ensuring that it's informed risk appetite. Could we therefore have that triage and directing to services based on the director of services in a more confident way, but knowing that once patients are referred, they will be looked after. The other thing that I'm floating at the moment, just talking to colleagues, and every colleague I've spoken to has a solution. It's supporting them to make it happen, and that's the bit where the 12-week becomes important. And so, for example, looking at potentially having that triage process in place, and so the colleagues have described what that would potentially look like, and we could definitely work on that as a test area. But that's something that we'll definitely need to be doing with a considered approach, given the risks associated with that, and also returning back on appointments scheme rather than unscheduled approach for a lower clinical needs cohort. MIUs agree completely with the issue that again, the pathways to some of we're going to be strengthening where they are in existence. So, for example, with YGC, Glenclwyd, we're going to be looking at pathways into MIUs. Virtual ward community setup. Caroline and colleagues have spoken about this. We are spending quite a bit of money around escalation capacity. Actually, could we not repurpose some of that in a much more considered way and looking at community capacity and looking at the step-up capacity potentially. So patients are in the right environment, right care. But we need to explore that to make sure that it is indeed a right, safe alternative. And again, that's something that we'll be exploring as well. The mutual aid conversation between our sites, that is very much a reality, and we are discussing it. But we also need to bear in mind that all sites are currently pressured. So today it might be that the front and ambulance handover is fine because YG could be accommodating a lot more in the corridor, but we are looking at the weights and we think, oh, actually, they're much better. But in reality, it's pressured, but managing differently at that point in time. So again, there needs to be that considered approach, and maybe going back to looking at patients who are delayed. If there are patients that are waiting to go to repatriating into East or West, could we accommodate them differently and therefore creating capacity at that point in time? And the other thing that I also want to pick up on is the health and equality element, and really in particular, because what we're also finding generally, the picture is that patients from the most deprived areas tend to access emergency care out of hours. And out of hours, when everything's mounting up, the delays become more. So we're actually reinforcing that quality of access. So we do need to look at that. And I think Jane, you and I touched on this briefly a couple of weeks ago. So yeah, those are the things that we'll be picking up on population wellbeing in particular, but I'll obviously pass over to Carol if there's anything else that needs to. Carol.
Great. Really good discussion. I was trying to think of how to get into this, and I thought, God, I've been 30 odd years in the NHS. I've probably spent quite a lot of those years focusing on this issue. And I think if we climb on top of the mountain just for a moment, this is the stuff that really reminds us that the NHS needs to change because the public need is changing. So if I think back to the 80s when I trained as a nurse, the A&E department, as it was called then, really was about accidents and emergencies. It was about a lot of people having heart attacks, and the health and safety legislation wasn't as good. You know, we weren't quite a safety conscious country, and so there were lots of accidents. The needs of our population have completely changed over that time. Our demographic has changed, and I don't think the NHS and other sectors have changed as quickly to keep up with it. So what we've got in front of us is some focused work for the here and now, in terms of the 4 key areas where in the immediate to short term, we think we can get some benefit. And those even marginal gains across those 4 areas will add up to improvement. And I'll just touch on what improvement looks like. But when we're really getting into strategy and long-term planning, we've got to design solutions for the longer term here, because it feels a bit like sticking plasters at the moment. So just a couple of comments to add to what people have said. So in terms of moving the front door, I think somebody talked about, I think it was Rian mentioned, what we talk about the back door, and I will come back to that, the front door. So supporting people who fall in the community is key. That is the highest number of attendances. And actually the people who fall end up with the longest delays through the whole system, and they have a worse outcome because of those delays. So just a simple thing, I met with the ambulance service earlier this week. We're both committed working together on this, is there's been a practice for people who fall to leave them there till the ambulance comes. Actually, the balance of risk here, talking to Claire's point, is it's better to pick people up, because actually long waits on a floor starts the decay of deconditioning and illness. So that there are very tangible things that we can do, but in the longer term, we need to offer different alternatives to only pitching up at ED. We can start some of that work now.
And can I just mention there's something even before there is adaptation in people's houses, with care and repair, for example, and housing associations to assist in the work, so that people have the appropriate environment at home so they don't fall in the first place.
And I was going to come to that. And actually, you're absolutely right in terms of, so Helen referenced the number of different services that there are since the 80s/90s, maybe a bit. Since the Wanless report, some colleagues will remember Wanless. There were Wanless monies. I remember this so well. And then this team popped up. This team popped up. There's a huge fragmentation in primary and community care. The thinking now is around simplifying, standardizing, and streamlining that. Really about place-based, and that's our big. I look at Gareth for a moment in terms of our primary and community care strategy for the long term. The fundamental aspects is place-based, bringing teams together rather than fragmentation, because it is with that, David, that our teams will know their local population. They'll know, Mrs. Jones, she's getting a bit, frail on her feet, and the local voluntary sector organisation will be able to pick up the phone, can we get her a rail, and those sorts of things happening proactively rather than, afterwards. So I was going to mention that in terms of the ED and EQ, I think there's a couple of things in there. We talked about safety earlier, and I think over winter we need to keep that environment safe. We need to speed up the time to assessment. That is a bigger picture around job planning and how we enable that to happen. But that is the place where all the eyes go, and we'll need to have some of a break glass type arrangements in place. Mike picked up the pharmacy. We do have discharge lounges where people will go and wait for their pharmacy, but we know there's more to do on pharmacy there as well. And then Mike, there is diversions, pizzas working across, so that's really important. On risk appetite, I think there's a risk appetite issue about individual patients and the assessments and discharging sooner with a safety net is what I would probably say. This dreaded unsafe discharge that was drilled into us when we trained, and so we've got to build some safety nets around that. But I think the bigger point on that is almost what's our organisational appetite to do different services, and how far will we step into this issue and problem. People have covered the Royal Alex, that's exactly it. And I think this matters to people. David and I were in a meeting with some retired clinicians, people who are still interested in these matters. So I think going back to what does improvement look like, it will be access, it will be safety, and it will be people's experience. So we'll be tracking those things, triangulating those things over this next 6 months to show. And then on planned care, because you mentioned it, and I want to jump in on that. There's a big risk to the planned care work if we don't do that.
Absolutely.
So Imran is delighted that we're going to have a weekly check-in on UEC, a bit like we've had on planned care, starting tomorrow. Thank you.
Well, that's good news. No, thank you very much. There were lots of issues raised, really important. This work goes to the heart of many people's experience when they come in contact with help. So really, really important work. And the good news that Gareth, in your role as chair of committee looking at performance, we really need to be cited on progress and any issues around this work, as well as the planned care work. So we look forward to seeing that happen in committee as well. Ond diolch yn iawn I chi gyd am y gwaith. Diolch Imran.
Thank you for all the work. Thank you, Imran, for undertaking this work so carefully. Great. Next item. Just to note.
Wrth gwrs bod bwrdd mis Tachwedd hefyd yn gyfle I ni.
November board is a time to look at the winter plan and how we will try and cope with the additional pressures at that point. Everyone happy for us to move on to the next item? So Healthy North Wales report and the work there. And I will turn, I think, to Jane, first of all, before welcoming Brian and Terry.
So I'm going to take it that people have read the report. This North Wales is almost a framework about how do we start to move that agenda really to how do we keep people healthy, with a focus about what as individual organisations we should be doing around that agenda, and how do we work with partners, recognising that that agenda about keeping people healthy is not in the power of one organisation. So the report sets out some of the key areas that as a health board we've been concentrating on, particularly, and it's very relevant from the last discussion, how do we start to move the models around primary care to a much more holistic model, which brings in communities, the voluntary sector, as well as statutory bodies. How do we move from a very medical model to one that is a much more social, psychological, behavioural model, recognising, again, from the discussion, that a lot of what people are facing in terms of need is very different than it was 40 years ago. People living for very long periods of time with chronic disorders, which require us to work much more in partnership between the individual and the family who've got those conditions and services. And finally, starting to think about more broadly what enables people to live fulfilling lives, and what are the things that the interventions that may be more effective, whether that's social prescribing or the social interventions that Terry's been leading the work on in Hearts and Health. We are also, because we're really keen, because always the challenge on this is, but what impact is that we are evaluating all of these as we go along. What we have been able to show, even from the sort of 3 pilot on the inverse care law work on primary care, the impact of that and the potential of that, which is why we now want to expand that more sustainably across the health board. What we've been able to show from the arts and health is you can have a real impact on some very challenging communities. Some of the work we've done around the forensic mental health services, for example, all demonstrate the ability using these types of models. We're now starting this discussion across our partners, our task and finish group, really to start to think about how do we really move this agenda to keep people healthy, to be something that's at the forefront of all our organisations, not just health. Our police colleagues, for example, say, we've got to get into this prevention space in a very different way. So really, that's what the report is. It's a stop taking time, but a real sort of desire for you as a board to understand this and to sort of have this discussion about how we can maximise our ability to change how we interact with people.
Diolch yn iawn. Jane, unrhyw sylw o gwbl Brian, Terry, unrhyw beth ydych chi eisiau deud? Cyfle i chi ddeud hynny rwan. Any thoughts you wish to add, and I'll open up for questions. Diolch yn iawn. Thanks for joining us this morning too.
Yeah, really the report, thank you for having us on the agenda. Really appreciate the opportunity. It was to bring to you the progress that we've done to date, as Jane said, but to really outline how and why that's going to shape the discussions that we'd really like to have today, to say how do we move forward, not only as a health board, but really with our partners, to say the whole North Wales wants to move to this wellness, this prevention agenda, and how do we do it? So as Jane says, there's some work still going on for the remainder of this financial year, which we really hope will shape that going forward. So around the implementation science of how we do it, but also we've got some work with Bevan where we're looking at how do we put communities at the heart of that discussion, around how they want and expect us to transform services. So it's a step away from that paternalistic model where we come in and do to communities. As we've heard from young people today, it's fantastic. How do we actually go and meet communities on their terms and understand what it is they expect from us? So really just a provoke discussion. Thank you.
Diolch yn iawn. Terry, do you wish to add
Yeah,
anything?
again, thank you very much for asking us and for inviting us for today. And from my perspective, from Arts, Health and Wellbeing, I was really excited to hear some of the discussion already this morning and have been frantically scribbling notes. I think there's lots of ways that creativity can support us and provide creative solutions to health and wellbeing. In terms of environmental work, hearing about the design of chairs, you know, the look and feel of those can be really important for well-being. Hearing about education and hearing the lovely poster being really well appreciated from our young people in terms of educating and informing and being able to deliver messages. And some of the other items that I know have been really key for the board in terms of compassionate leadership. So I think the ways that we can support our staff in terms of creativity and some of the other programmes of work within Well North Wales that can have the ripple effects, because staff are also potentially patients, their families and their loved ones, their relatives, their friends are also patients. So I think there's a real advantage to how we work with our staff on some of this as well, and how it can help us with some of the things we've talked about, care closer to home. We engage a lot with our partnership and community, and the strategic framework has very much been designed through engaging with communities and partners, and they're really keen to work with us. So the falls prevention that was mentioned earlier, you know, we were just having a quick discussion there saying, you know, wouldn't it be great if people in their 40s and 50s could have, you know, recommended socially prescribed activities so that we try to stop them ending up in the system later on. So I think there's lots of possibilities for this work, and just really, really excited to be here to share some of it with you.
Diolch yn iawn. Reit, unrhyw sylwad, unrhyw gwestiynau gan aelodau? I'll turn to Claire first. Claire's been involved in quite a lot of this type of work, I know, so I'm sure you've got a contribution to make, Claire.
Thanks, Jane. Thanks, Brian. But did I read your name? Terry. Sorry, Joel, Terry. Really good to see this here today. And I think it starts to mark the step change we've all talked about at board a lot, about the need to invest in prevention work to enable us to deal with the pressures on demand for services. But it's a really long-term change. So really look forward to the business case coming forward that's going to make the case for how we start to make more investment in this area, because we know we need to do it, and it will involve brave steps initially, because it will perhaps put pressures on other areas of spend while we free up resources to do more around prevention. In terms of the paper itself, it felt like we'd done quite a lot in terms of starting to talk at the RPB level. We've done some work in communities around the inverse care law work, but it just feels like there is a lot more to do to start to really build up from what communities want and need in terms of their own health and wellbeing. So I guess there's a question for me around what you see as the role of the PPHP committee in helping to support this work, and indeed the stakeholder reference group. So how can we, through our governance structures, really help to shape this? And then just a very specific question. I was really interested in the focus around the arts work. But it struck me this week that I was listening to something around education and the great work that's going on in some schools now across the region around local culture and local history. And so we often revert to arts as being one of the routes for helping people to manage their health and their well-being. But I just felt that there are other things we could be doing too in terms of you know, encouraging people to understand their local history, geography and culture as well. So is arts just step one, I suppose, in simple terms, is what I'm asking. And then one final specific question. So the document identifies a vision. Is that the Well North Wales vision, or is that the BCU vision? And how will that align, if we agree that today, with the work we know we're going to be doing over the next year around our 10-year strategy? So I'm just conscious of, for all the right reasons, us kind of setting off siloed, maybe, visions that may or may not fully align with where we might end up with work we're doing on the 10-year plan. So, but thank you. Great to have this paper here today.
Great, thanks. And we get some further questions before giving you an opportunity to respond to some of them. Karen?
No, just to build on Claire's point, really.
As Claire said, it feels very high level RPB level. Whereas we know we've got a lot of potential for partners physically on the ground to support us, and we could stretch our activities a lot further in partnership with people who are actually working at a grassroots level. What tends to happen though is there's an assumption that people working in the third sector have got the money to do that. And so if we want to partner, we need to be able to match fund projects that they're delivering, or indeed invest in third sector to help us meet some of these preventative targets that we need. So it was just to build on Claire's point, really.
Good. Thank you very much. Gareth?
Just to say, welcome the work. I take both Claire and Karen's point, but I am very encouraged to see the RPB setting up this task finish group, and if it's appropriate, I make this offer separately. I'd be quite keen to be involved with that, because I'm keen to be involved with the RPB generally, and this fits in very well with my role with primary community care. So.
Great. And just to add to some of the challenges of this really important work, and if we think in particular the context for arts at the moment is particularly difficult from the finances and other aspects in general. One of the things we've talked quite a lot about as a health board is our ambition and our understanding of the need to invest more in preventative work and in work supporting people where they are and helping people along their health journey. So there's a big question about what's our commitment to that, not just in terms of the saying, but actually the doing, and what does that mean? Now, together with that then is, how can we evidence it? That's quite difficult, actually. I understand that. How can we evidence effect and results and so on? So just an extra bit of consideration there for us. I think as a health board, we are committed to this 100%. And we want to commit more. We want to achieve more. And I think we need some guidance in terms of how can we do that and what does it mean. So I offer an opportunity to Brian and Terry first, and some of those big questions we'll turn to Carol and Jane. I'm not asking you to start committing £10 million on the health board, but thanks for the offer. But any thoughts, to help us get to that place we want to?
Yeah, so to come on Claire's point first, then we're very keen that we use the existing governance groups that we've got. So let's not reinvent the wheel. Let's use those governance channels that we've got, not only internally with the health board, but we're also reaching outside of this space as well. So the ask is for people to review their terms of reference and their membership to make sure that the right people are there making those decisions in an informed way. I think the key to it really comes back to Angela's earlier point around operationalization. It's around the delivery of how we actually make this happen rather than the government that sits around it. But I get that we have to start with the governance because we need to seek the approval to do something so radically different. So yes, noted, we will certainly bear that in mind. In terms of the vision, I would come back to Carol and Jane to comment on that, but the vision that we've set out there is nothing really contentious. It's to say, we should be aiming to reduce avoidable inequalities. We should be aiming to improve longer term population health and well-being. And I don't think there's anybody in North Wales that would disagree with that. No. And whether that's our vision or whether that's the vision of the health board, I'd leave that to Jane and Carol to come back on. Karen's point around partners at the grassroots level, we've done a lot of work over the last sort of 12 to 18 months around engaging with voluntary service councils, because they're the people who've got those established relationships. So it's very much piggybacking on what's already there, standing on the shoulders of giants. It's not us going out to create those relationships from scratch. We're working with the organisations that have already got them. We're doing a lot of work as well to improve the resilience and the sustainability of the third sector. So we're trying to shift that and influence that shift towards longer term contracts. So we stop this and break this cycle of annual year on year funding. We're all in this together, so I think we as a health board, we've got a role to play in this, but we're also influencing our partners to do similar. And then just finally to come on Gareth's point, I absolutely welcome your volunteering to join that task and finish group, and we'll be in touch very, very soon. Terry, have you got anything to
Yeah, I would agree with what Ryan said. Claire, if I can just say a little bit about your point about schools and local culture and history. Absolutely. I think the language in the past has been about arts in health, arts and health. I think it's shifting now. It's being used a lot in England, creative health as a term, and very much about considering culture, heritage, creativity under that. So, I mean, I take quite an expansive approach to this, that anything from gardening, woodwork, photography, design, it should all come under that. But as a very small capacity team, I think we need to think then very carefully about our involvement with that. But then working to connect with Karen's point, the partners becomes really crucial. We know our partners are really keen to work with us on this. And actually for some of them where funding is a challenge, we can support them because it will help them to access some of that funding. But certainly I think that would be an important aspect to this work. And if I could just say one last thing is that connecting with the schools, absolutely, the Arts Council of Wales do an awful lot for their creative programme with schools. I think the key thing for me is that about creativity is not just for young people. I think that's one of the biggest challenges, is trying to make shifts for all of us, and some of it might feel a bit strange or unnatural initially, but you know, I think by introducing some of this into all our lives there are real benefits, and the more we can try to model that, I think it's to the benefit of our populations.
A great example, by the way, this week of the link between history and music and the arts is the opera to commemorate the Gresford disaster in 90 years. And if you haven't heard that, take an opportunity, and that was a good way of linking everything. Right, a couple of comments then, Carol and Jane. Karen first, and then I'll bring Pam in.
Yeah, and just to come back on the CVCs, and I know if Ursula was here, she would probably be the same as well, but we had a really good conversation, Ursula and I, last week, and the thing with the CVCs is whilst they're the overarching body, they don't actually always know exactly what's going on the ground, because they can't possibly know what every third sector partner's doing. So I just don't know how we get that intelligence as to, you know, the real stuff that's happening with an overarching body, but I just part of that as a thought for you.
Yeah, no, good point, and the potential to tap into all that community activity and energy. I often say in the county I live, there's almost 40 groups active on a regular basis, you know, so there's a great opportunity. Pam, did you want to say anything?
I suppose it's just, I'm sure Karen might cover some of this, just go back to Claire's point about the committee. Yes. I would suggest that the vehicle in which the sort of progress and next steps oversight definitely needs to be through the PP. Committee. So I think we just need to build that into the programme.
Yeah.
I think also go back to Claire's point around the connections with all the other strands of work. So I just really wanted, just maybe that's an action from the board.
Yeah.
Great.
Diolch, Pam. Carol, Jane, over to you.
Great. Great stuff. So I'm going to just cover off a couple of things. Originally, Claire, we were going to have the arts and health framework, and felt that it was such an opportunity to really have a slightly more strategic sense that, you know, we asked the guys to bring forward this work. So thanks very much to the team. A lot of conversations happening. So I see this work as our warm up to our long-term strategy. Not, you know, the last thing was that over there. So it's the warm up to it. I think with this stuff, there's no sort of magic switch to flick. We start to build a momentum and a common sort of understanding. I think it's great that we've got this here, because the purpose of the health board is to improve health and well-being, as well as providing secure excellent services. And when we look at the balance of our agenda, it may well be that we often operate in that second purpose. A couple of key things for me, you know, and really taking a look at what it is to live well through the whole life course. So what is health and well-being? What is it to people? and we start to get into things, you know, about well, what does community mean? What does social connection and happiness and the link between those things and general rating of well-being? And we have the happiness surveys and things like that, don't we? These are sort of the things that someone might look and say, what's the health board talking about that for? But these are the things that help people to feel well.
Yeah.
Even if they have a physical or even a mental health issue, it's about their life. So when we talk about biopsychosocial models, it's about how you live your life. And we're not always about trying to fix people, because some things we can't fix, but we can contribute to people living their best lives, really. I think we start to then think about, well, Darcy last week or the week before talked about prevention. This isn't necessarily a new thing, but I think we're becoming much more aware about the impacts of different types of health and wellbeing interventions. And I was thinking about green health and blue health and all of that sort of thing, the environment basically, and our focus on that. And while we talk about the RPB, we should also talk about the PSB, Natural Resources Wales, the police, you know, feeling safe in your community helps your wellbeing. So that much broader sort of perspective. And then just when we think about the third sector, but also community partners and communities as equal partners in planning. And that's what we'll need to do. It's not just, as Brian was saying, you know, about the commissioning them as a provider. They are equal partners in planning for the future. We need to know when to get out of the way. So as a statutory sector, we're not the best place to do certain things, but be clear about where we can help and be available for that. And then the big picture on, well, what about the resources is, I'm looking forward to the time we start to talk about allocative efficiency. Sorry, it's a bit of a funny term, but out of our £2.2 billion that we have, where should we spend that best to get the best outcomes for the population? And I'm sure it's not in hospitals.
No.
I'm pretty sure there's quite a big proportion of that. If we spent it differently, we could get a better outcome. So it's not necessarily about more resources, just to reassure us, but thinking about where we put our resource for the best outcome. So I think it's great, and so thanks to Brian and to Terry.
Anything to add, Jane?
Yes, so three things. The first of all is that this is not intended to be a top-down, it's bottom, it's but intended to be both. So it's starting from both ends. We need to do the top-down to get the framework and the buy-in and to get the partners. And we want to use the structures, which is why the RPB. But one of the things when we took it to the RPB and did the workshop was the agreement that actually the task and finish group needs to be a much wider constituency, because actually it's all organisations in North Wales. And this is how do we come together to address this. At the same time, and in things like the social prescribing and the inverse care law work, we are very clearly starting at the community basis, and how do we bring together the groups, partly your question, how do we bring together groups, but also recognising doing the top down allows us to work very differently at the community groups, because some of our partner organisations have much better links into those communities, and it means we don't duplicate, we don't over intensify gaze on some communities who really are not comfortable in that space, but actually work with communities. So I think that top down, bottom up is really important. The second on the strategic is I would get to Carol. This is not about a different thing to the 10. This is about how do we bring together not just the health board, but that real conversation about what does health and well-being look like, and how do we work together to maximise health and well-being, which should inform the 10-year strategy and start to think about it. And my third point is there is also a question we're always asked: how do you show the benefit of this? Increasingly, I'm getting to my question is, if we don't do this, we do not have a sustainable health and care system, we are going to have outcomes for our population. That means this will not just be a health issue, this will be a social economic side, social impact issue. Health is now the biggest limiter on people being out of work.
Yeah.
It is having a huge impact in the viability of some of our communities.
Yeah.
We need to look at different models, and we need to have that braveness that says, actually, we cannot do what we did for the last 50 years for the next 50 years, because that will not solve the issues that we're now facing. I would also say it also means we are going to need to look differently at what we measure and value in terms of the outcomes.
Yeah.
So increasingly, and we've been working again with the voluntary sector a lot about things like social return on investment, being able to demonstrate a wider set of impacts that, if you intervene in a different way, are going to have on people and their communities. So we have built-in evaluation into this because we know we're always going to get the question, does this have impact?
Of course.
And we think that actually we are probably getting better evidence for the value of our intervention than is actually often provided for more traditional interventions. But we will keep that as a key part, because actually the end of all of this is all about how do we have impact and how do we improve outcomes for our communities, and particularly some of our communities and individuals who at the moment feel often furthest from getting good outcomes.
Diolch yn iawn. And just those who are unsure, RPB is Regional Partnership Board and PSB is Public Service Board. Those acronyms sort of crop up quite a lot, so just in case that needed clarifying. Diolch yn iawn am y gwaith ardderchog, a dyn ni'n edrych
Thank you for the excellent work, and we're looking forward to seeing progress and development in this area. And are we all happy to support this work, to support the framework, and to note that there will be a further business case for resources long term, and that we're happy to support that principle. But moving to intervention, where we engage with people in the community to try and improve opportunities to live healthier lives. Thank you very much, and thank you for the excellent work. Looking forward to having further discussions in the committee as noted. Thank you. Okay, we'll take a break. It's almost 10 to 12. Reconvening at 12.
So come back a little before 12. We will be restarting on the dot. Diolch yn fawr iawn. We now go to adverts. If you want.
Oh.
Thank you.
Ti'n Aled? Fiona, can you ask Philippa to make Aled a translator, please? I have emailed her. Hi, Fiona, I can hear you now. Can you hear me? Okay, Aled needs to become a translator, and Philippa needs to do that. I've emailed Philippa, but she hasn't answered, so I don't know if you can give her a prompt. Yeah, okay. Yeah, thank you. Okay, diolch. Do you know what's happening, Fiona? Okay. So if Aled speaks now, I don't know. Ask Aled to speak. Yeah.